the surgeon is there with her, and I'm asking the surgeon, like, well, could this be arterial? Like, is there an underlying bleeding disorder? Just the basic, right? Basic question. And then the surgeon was like, well, I made a stab here and I made a stab there. And so in that moment, I was like, wait a second. Are you a doctor? Why did you say, did you mean incision? Like, what's going
Right.
on
We
here?
don't
And
usually use the word stab typically.
no.
This is Med Spa Mayhem, the podcast all about the chaotic world of medical aesthetics. From Botox to lasers to IV bars, learn how to tell real versus fake, legal versus illegal, and safe versus potentially deadly. Hear the crazy stories inside the med spa world and find out what questions to ask and how to spot the people cutting corners. I'm your host, Dr. Kate D. Together, we explore the wild west of medicine that is the aesthetics industry. Hi, this is Dr. Kate D, and I'm here today with Nadia Nabavi. She is an ER physician who originally went to the Medical College of Georgia, did her residency in emergency medicine at Emory University, and a fellowship in EMS and disaster medicine also at Emory. And we're going to talk about med spa complications seen in the ER. Thanks so much for being with us today, Nadia.
Thanks so much for having me, Kate. I'm glad to be here.
So I've been really looking forward to our conversation because a lot of times people just send their patients to the ER if there's any med spa complication. And I'm just wondering on your end, what happens next? So the thing that's been in the news the most lately is botulism, because there's been a whole bunch of botulism cases from fake Botox across the country. And I was just wondering if you've ever seen botulism walk into your or be rolled into your ER.
So, I haven't thankfully seen botulism in the ER, and not to date myself, but I trained during a time when Botox wasn't widely used for cosmetic purposes. And botulism was just one of those board questions often framed as, a floppy baby. So a baby who is no longer moving its arms and legs and not really sucking comes into the emergency department, and then the parents tell you that the baby had some honey or some home canned goods. So that's sort of the way that it was always presented to us. And since all of this fake Botox and then, as we've heard across the world, botulism outbreaks in different areas, we've all had to brush up on how botulism presents.
So if someone actually had botulism from fake Botox, how would you figure that out?
So, factoid first, because I love weird factoids. So but first, observed and recorded cases of botulism were actually noted in people eating sausages in southern Germany in the 18th century. So when
sausages,
yeah, in Germany, of course. And when the bacterium was isolated, it was named botulinum for its association with sausages, as the Latin word for sausage is botulus.
Okay.
Yeah.
I did not know that. That's really interesting. Okay.
So just to sort of backtrack on what is Clostridium botulinum. So Clostridium botulinum is a spore-forming bacteria, and it lives in soil, river, salt water, and by the transitive property, it's basically found on everything. So that includes fruits, vegetables, honey, seafood. Clostridium botulinum is most often found in its spore form, which is sort of like its form that helps it survive austere environments. And so these forms are generally harmless until the spore begins to grow out into active bacteria and produce this neurotoxin called botulinum. And a spore will begin to grow and produce neurotoxins in certain environmental conditions. So it has to be low oxygen, low acidity, low sugar, and low salt environments. And then as humans ingest these spores, we actually have a highly acidic GI tract. So these spores don't really go on to produce toxins. But we have isolated the botulinum toxin because what it does is it affects the nerves. So it binds to nerve endings that join muscles. And this prevents the nerve from signaling the muscles to contract. And that's why we love Botox, right? So we paralyze those muscles so they don't leave lines or wrinkles. So if someone had come in and recently had Botox done, and sometimes it can be hard to differentiate between the two, because of course, if you, for example, inject it into your forehead, you would expect to see that the forehead would be droopy, and if it's not done correctly, the patient may have even if it's the eyelid, but you would expect to see other signs and symptoms outside of the area in which the patient was injected. So if they were injected in their forehead, but suddenly they're complaining of double vision or they're drooling, and oftentimes this neurotoxin has a predilection for cranial nerves. And so what that means is these are nerves that exit through holes in your skull out to your face and neck and your diaphragm. So if you start seeing that someone has paralysis of cranial nerves on both sides, then you would have a high clinical suspicion for botulism.
Gotcha. And how many people end up, well, I guess this depends on how much toxin you get exposed to, right? But if you get enough, then you'll have weakness throughout your body. And then ultimately, you'll have weakness in your diaphragm, so you won't be able to breathe.
Yeah.
So that's why, if it's severe, you end up on a breathing machine in the ICU.
Exactly. And if you have a high clinical suspicion for botulism, so someone went in and they got injected, forehead, cheek, whatever, their masseter, and then you're starting to notice that they're having weakness in other areas, it's symmetric, one of their eyes isn't moving the way that they should, for example, then you can inject the antitoxin, which lessens the severity of the disease because it neutralizes any toxin that's not yet bound to nerve endings. The issue here, though, is that the nerves that are affected will require time. Sorry, go ahead.
Yeah, well, I just want to not scare our listeners too much about this, that the reason that there is really no chance, if you just have a normal injection of Botox for your forehead or whatever, you're not going to get botulism. That's a teeny tiny amount of the toxin going into these little muscles, okay? The reason that there was this flood of people a month or two ago getting botulism is because they were getting fake Botox off the internet. And this wasn't the real purified Botox that you get from Allergan or any of the other toxins that we legally and legitimately use in this country to treat wrinkles. This was an overdose because they were getting this through an illegal, cheap source. So I just want to make sure people know that, getting it from a legit place is not really scary. The scary part is all these people doing it outside the system, illegally, out of hotel rooms, or even out of a clinic if it's owned by somebody who can't legitimately buy Botox. They're going to get it somehow. And it's really easy to buy fake Botox off of the internet, especially through Alibaba, where you can buy almost anything from China. And it will be a fake, but it will be, available.
I was going to ask you, when you're injecting Botox, what does it always come in a vial? Is there a way that a patient can identify that this isn't real?
Yeah, well, interestingly, in the news articles a month ago, they did describe what the box looks like, or the one box that was confiscated from a nurse in Illinois who had ordered her Botox off the internet. It was a spoof of a real box. It was not the right exact logo. It said on it 150 units. So Botox comes in two sizes, 50 and 100. Most people just buy 100 unit vials. 100 units is not enough to give you botulism, even if you were to inject it, directly into your vein. So typically treating facial wrinkles would be, anywhere from, 20 to 60 units to treat, various parts of your facial wrinkles. Masseters are usually 40, so 20 on each side. So, the most you would ever do if you're doing your entire face plus your masseters would be maybe 100, but that'd be remarkable. Actually, to treat hyperhidrosis is 100 units. So the cases before this, the only cases I could find were cases where people were putting much larger amounts in the calf muscles and calf muscles are very, very huge compared to any teeny tiny muscle that you have in your face. People were using 200 to 300 units to treat the calves to try to reduce them. This apparently is somewhat common in Asia, where having nice slender calves is more attractive, apparently. But there you're getting into a high enough dose that you can actually see some signs of botulism. I don't think that's enough to put you on a ventilator. But yeah, 200 to 300 units is astronomical. We would never see that in the United States typically. But if you're getting fake Botox and you don't know the dosage that you're actually providing, because the box is fake, so maybe there's some real Botox in there, but it hasn't been purified properly. So that's what happened at this last outbreak. As far as I know, it was 22 people sent to the hospital with botulism in America, and but I assume none of those came into your ER.
No, they didn't. And of those, I think the most recent update from the CDC, and they have a website as well for anyone that wants to go and read it about what to look for when you're going to see a practitioner and questions to ask. But based off of the most recent CDC reporting, thankfully none of them needed the ICU or needed breathing, needed to be put on a vent machine, thankfully.
Well, thank goodness. That would be just an incredible disaster.
So is there like a lookup tool that patients have where they can check to see if a clinic is licensed for this?
Well, unfortunately for clinics, no. For practitioners, yes. So as you know, any doctor can be looked up through their NPI number, or National Provider Index number, I believe is what that's called. The ABMS is a really great source. So the American Board of Medical Specialties has a lookup tool where you can find out not only a doctor's license, but what board certification they have, and if indeed they do have board certification. And then the nursing board has the same thing. So there is a link, and actually it's in the book. Both of these links are in the book, but you can just Google them, and you can look up any nurse's license. And so you can find out if somebody's a nurse practitioner or an RN. But then, if somebody has no license at all, you go to look at them, you won't find them. And then you might wonder, well, do they have something that I don't know about? Maybe I'm not looking in the right place, but there are a lot of people providing these medical services, including Botox, who have no license at all to practice medicine. And those people are committing a felony, even if they don't harm you. But practicing medicine without a license is a felony. But unfortunately, that is really incredibly common. So it is really important to look up your provider and make sure that they actually do have a license. And if they're an RN, they can't practice on their own either. They should be practicing under a doctor. So then you'd want to find out who their medical director is and find out what their specialty is. And do they know anything about aesthetics? Because many RNs are operating under doctors' licenses who actually don't oversee them at all, don't know anything about aesthetics. I have one former employee who on her website now, she's practicing independently. She lists a retired gastroenterologist as her medical director. And I don't know this 100%, but I'm pretty sure that this person doesn't practice aesthetics in any way and is not overseeing this RN. And that's not legal.
Yeah, that's terrifying. Even more terrifying is I have also been asked to oversee med spas for a nominal fee. And it's crazy that I'm sure that there are other people that would love to have sort of mailbox money where they're just signing their names on a bottom line.
That's what they call it, mailbox money. What did they offer you out of curiosity?
It was like $2,000 a month.
That's high, believe it or not. I've seen people offered on the internet through Facebook $500 a month to use their medical license to practice medicine. And by the way, so that our listeners understand this, is that the doctor or potentially nurse practitioner, depends on the state. Some states allow nurse practitioners to practice independently, but it's the doctor's liability. So if something bad happens to you, like you get botulism, if you're going to sue someone, it's the doctor that you'd be suing, who you've never met, who's never been to the spa, who doesn't know anything about aesthetics. And I think that the vast majority of times, the people getting this mailbox money don't realize what a huge risk they're taking. And even if they trust the person, I trust her, she's good at RN, I worked with her in the OR for years. They don't realize the kind of risks that they're taking, especially with filler and lasers that can have really terrible consequences. I mean, botulism is the least of the problems, I think.
Yeah.
That brings us to filler complications. I'm curious to know whether you've seen any filler complications come to your ER, and if you had one, what would you do? Are you guys prepared to treat filler complications in your ER?
So to clarify, no, most emergency departments don't manage filler complications. We don't even have a hyaluronidase in our Pyxis. Oftentimes, when you get to the occlusion, like the vessel occlusion that can lead to blindness, and that's technically an emergency. But most of these filler complications are considered urgent, meaning that they can be managed in 12 to 24 hours. And so oftentimes if the patient comes to the ER and they've got an area of skin that, oftentimes it originally just looks infected, we would oftentimes start them on antibiotics. And then I would call the med spa to speak with their on-call med director or the physician that's on and let them know what's going on to facilitate outpatient follow-up. But no, the ER is not the appropriate place for anyone that's having a filler complication unless it's something more severe. I'm losing vision. Obviously, I'm having symmetric weakness. I can't swallow. I'm having difficulty breathing, things like that. Kate,
Got it. Okay. And that's interesting because as a practitioner, I consider a filler occlusion an emergency. So, I mean, that needs to be treated right away. You can't really wait till tomorrow. You've got to just do it now. If it's not treated within 3 days, you can pretty much guarantee that it's not going to respond at all. But the responsiveness goes down, every hour that it goes by that you haven't treated it. So the scary thing is there are a lot of places out there that, they're not prepared to treat an occlusion, especially these places where, they're not providers at all. They've ordered a hyaluron pen off the internet. They're working out of, a hotel or their house or a beauty salon, or they're one of these people who've set up shop like a business with an Instagram account and they have an actual spa location, but they have no licensed providers, no insurance, no nothing. And they don't know how to treat it and they are not prepared. And they're just, they just send those people to the ER. And then the ER would have no idea what to do.
Yeah, we get this a lot. We call it dumping, right? Where another person sort of has done something and they don't know what to do, or they ordered a test and they don't know really how to interpret the results. And so we become sort of the dumping ground of, I don't know what to do, but I'm scared that it could be something more severe, something to send you to the ER. And we feel bad too, because, when someone comes to the emergency department and gets triaged and sees us, the facility fees alone are over $1,000 usually. All to be told, actually, this person is the person who sent you here was the most appropriate person to manage this. So for Kate, when you have a filler complication, like, what do you guys do for it?
Well, we have a whole pile of Hylenex or hyaluronidase, so that's the enzyme that breaks up filler, in our fridge. I think we have generally about 16 vials of it, at least at any given time. And it should be recognized right away. So you can see blanching of the skin. You can see that the capillary refill is poor or zero because it happens right away when you inject. So hopefully the injector recognizes it for what it is, and then you immediately start injecting Hylenex. We actually have an ultrasound machine in our spa. I like to call myself a recovering radiologist. I know how to use ultrasound in it. I've taught my injectors how to use it, although they haven't used it for a lifetime. So I don't know how comfortable they feel, but I feel very comfortable. And so hopefully the ultrasound would help you either identify the occluded vessel and focus your treatment there, or at least recognize the area of it, because sometimes an occluded vessel is going to be really impossible to see, because vessels are really easy to see when there's no clot or no blocking in them because they are black on ultrasound and you can see flow in them. But the moment they're blocked, now they look pretty much like the surrounding tissue and there's no flow in them. So it's much harder to see them. But when they're blocked, you can see all this hyperemia around it. So blood flow is in all of the little branches around the area instead of in the main vessel that you've blocked. So you can actually see that really well with ultrasound. And so you can hone in on where to treat. And we probably give somebody an aspirin just to prevent further clotting. It used in warm packs, hot packs, to dilate blood vessels. People used to recommend nitropase, but they don't recommend that anymore. It turns out that that's not particularly helpful. And so there's a protocol for flooding the area with Hylenex and checking every few minutes. For the most part, it takes a few hours to treat and make sure that the blood flow is returned and everything's okay. And anybody injecting filler for a living has to be prepared to do all that as part of the treatment in an emergency. And if they're not, then you as the patient, if you have this complication, it's rare, but if it happens, there's really not much you can do. And I interviewed a woman a few weeks ago on the podcast who went to an ENT actually for filler, and two big problems with that. One is he used a non-dissolvable filler, and two, he was not prepared to treat an occlusion. And I think what came out from her story is he thought because he was an ENT, it would never happen to him. And it did. He hit a very major, huge branch of the facial artery, and she had a massive necrosis and lost half her nose, and she's scarred all up and down her face. And she wears kind of a prosthesis to replace her nasal passages and half her nose. It's pretty awful. And I'm surprised we don't see more of this. But, she is the one person where this happened to, and she's out there on TikTok sharing her story because she wants to educate other people to make sure they know this could happen. She never thought this could happen. She had been having filler for many years. I am absolutely positive there are people who've had occlusions and have suffered the consequences and are just not talking about it because they're embarrassed or they feel scarred. They wish they had never done it. They don't want to talk about it. I think that for any person who's this happened to, it would be a lot to talk about. It was very emotional for this woman to come on the podcast and share her story. It's hard for her to talk about it without kind of losing. And so, yeah, I mean, it's rare, but when it happens, it's devastating.
Yeah, I think that goes to that saying of, it's either 0% or 100%, right? Like it either happens to you or it doesn't. And I think that goes back to that.
Yeah. So what about complications of liposuction? I think you mentioned a couple stories when we were talking before. Do you want to share those?
Yeah, sure. So I think most ER doctors are averse to elective surgeries because we've just seen the worst of it. So I want to be clear, this is just like a selection bias. And, the only cosmetic procedures that we see in the emergency departments are those that have complications, right? So it appears to us that elective procedures are more dangerous than they actually are. So I had a recent case of lipo gone wrong, unfortunately, in a patient who was over-sedated during sort of a routine outpatient liposuction. So a lot of times for patients, in order to save money, they'll opt for an in-office liposuction procedure where they take a few sedatives, a few painkillers, and they take, one heck of a nap during the procedure. This patient was sort of on the older side. She had some underlying pulmonary disease that was, unfortunately, she was over sedated. And because she was over sedated, she aspirated, which means that, she wasn't like, every person produces saliva in their mouth. Sometimes what can happen though is when you're sleeping or you're over sedated, you can inhale that saliva. And then what that did was trigger her underlying pulmonary. And she was so sedated that she stopped breathing and no one really noticed until after the procedure when she didn't wake up. And she had these like very shallow respirations, so you could barely hear anything. So by the time that she got to me, she was basically apneic, which means that she was breathing like 4 to 6 times a minute. And that just goes to show,
and
right?
For everyone listening, that's not enough. Typically, a respiratory rate is 16 a minute or something?
Yeah, 16 to 20, so she was already over sedated. So it was probably all like just breathing minimally. And then when she aspirated, her underlying pulmonary disease flared up and then it caused her to retain carbon dioxide. And when you retain carbon dioxide, you develop what we call narcosis, right? So you start breathing even less. And so ultimately, she was probably breathing 8 times a minute initially. And then by the time she got to me, she was 4 times a minute and was barely breathing. And she came with EMS. They didn't even have a report from the physician about what they had given her. And so they said, oh, we didn't give her anything. She just got she was just got lipo just like that. And we're like, okay, that's not how this works. But we're just going to assume that she had gotten a bunch of meds. And so we reversed her narcotic medicine, and she still wasn't. Really
Which means Narcan, right?
Yes, exactly. So we reversed her with Narcan. She required high doses of it, which can sometimes happen. So she had high doses of Narcan and was like breathing just enough for us to hear sort of the underlying issue that was exacerbated. All the while, her poor family members were at bedside, just like beside themselves. And we had to go through the PDMP database, which is a national database that records any controlled substances that patients take, to see what she was prescribed and just assume that she had taken all those things before her procedure. And so prescribed both a narcotic and the sedative. So I had reversed her narcotic overdose, but we still need to reverse the sedative overdose because despite our maximal treatment, she wasn't getting better. And so then we ultimately had to give her flumazenil, which is the antidote to benzodiazepines, like Xanax, for example. And then she woke up perfectly fine. She was like, oh, is it over? And we were all like, sort of, but not really. So unfortunately, flumazenil doesn't last as long in your system. So we had to keep redosing it, and she ended up staying in the ICU. So, all that to say that, you end up paying for expertise, whether on the front end or the back end. So I think if you get a procedure done, please pay for an anesthesiologist to appropriately risk stratify you and monitor you during your sedation, rather than just sort of chalking it up to luck. And most people do fine.
Yeah, so it's a really interesting way to save money. It's cutting that corner. I think that a lot of people are interested in trying to get lipo and other cosmetic procedures as cheap as possible. And that leads to people skimping on all kinds of things. So anesthesiology is just one of them, but a really important one, because what they're doing is not only putting you out, but monitoring you and making sure you stay alive while you're out. And really, this lady was lucky to be alive, because they could have killed her and not even realized it until they finished the procedure and she didn't wake up.
Yeah, she was already knocking on heaven's door when she came to me.
Well, but she had so she survived though without any brain damage and
no, yeah, she
was
survived.
Okay in the end.
Yeah, she went home, and I followed up with her chart, and then I did end up calling the surgeon too to just sort of let him know what happened. And because sometimes the surgeon is looking at the thing that he or she is operating on. They're not really managing airway and breathing. So just to kind of let him or her know, kind of like, this is what happened. Just careful.
Wow. That's crazy. Yeah. So, and I would also echo what Dr. Woodman said a few weeks ago on the podcast, that, if you're doing anything like this, you really should be treated in an OR. That doing it in an outpatient setting where it's just, I'll just kind of get it done in the office, it can be super dangerous. And if anything goes wrong, there's no way to fix it, because you don't have all the supplies you need that would be in an OR.
Yeah.
And generally that also includes anesthesia.
Great point. I think that patients oftentimes think that if it's a procedure that can be done in the office, it must be minor.
Right. Well, what Dr. Woodman pointed out, which I hadn't really realized until he was saying it, is that, complications are rare, but if you get a bleeder and you need suction, there's no suction in an outpatient setting. There's no assistant, there's no suction, there's no all the things that you would routinely go to if there were this complication. So it's possible that you can do it and don't have a complication, therefore you get away with it. But that doesn't mean that that's the way it should always be done, because then you're not prepared. Let's say it happens in 1% of instances. How many procedures do you do a week? I mean, you do 100 cases. Now you could kill someone every 100 people. That's crazy. It just sounds insane to me. Saving money in that area is not recommended.
Yeah. Half the time we're looking for that 1 to 5% chance of someone having something severe, right? And so you just saying that, I'm like, that sounds just too risky. I don't like it.
Yeah. Well, my best friend from medical school was an ophthalmologist, and I really wanted to get LASIK surgery, and she really basically forbid me from doing it for the longest time because she's like, well, it's only a 1% chance of blurry vision, but it tends to be permanent. So, how can you afford to walk around, especially when I was acting as radiologist in the past, like, you need to see, so don't do it. And just, a 1% risk of something, if it's you, is 100% not okay.
Yeah.
So it's like, you can't take those risks. That's why, I know I write about this in the book, but like when choosing procedures to offer in my spa, I will not offer the service that has, any kind of risk of permanent harm. That's why I don't have an ablative laser in my place, because the risk of ablative lasers is just too high, even if it's just 1% to 2%. I interviewed somebody from the Rocky Mountain Laser College like 10 years ago when I was starting out. I was like, okay, in your hands, you're an instructor. What are the risks of hyper and hypopigmentation with a CO2 laser? He's like, oh, they're so low. It's like 1% to 2%. I'm like, and that's in an expert's hands. I'm like, well, that's too high for me. It's just not.
Yeah.
Anything in aesthetics is not worth any permanent harm. And that's just hyperpigmentation. That's not even, scarring and the other things that can happen. Anyway, getting back to our discussion, you mentioned another story about liposuction more recently.
Yeah. So some things that I think that we as physicians can sometimes forget is, we do these things for a living, and patients are not used to the things that we do. So I had a patient that had just had liposuction done and unfortunately had developed a infected seroma. So that's like an area of infected fluid under her incision. And she went to follow up with a plastic surgeon appropriately. And this plastic surgeon was like, okay. And they ended up just cutting the whole incision open to let it drain. Mm-hmm. So the patient at the time, and this is from her account, of course, was like, I felt like nobody really appropriately prepared me for what was going to happen. And all I did was just see someone just cut open my stomach and all this fluid come out of it. Am I okay? You are to just be like, am I okay? And so instead of, she has cellulitis, around the area. That was kind of the only thing that I was like, oh, we'll add on these antibiotics. But we really just had a therapy session where we just sat down and talked about, what happened. I'm sorry that happened and that wasn't okay. And, sometimes we forget that to us, it's just, this is every day, Monday through Friday, we're doing things like this. But we forget that our patients, we have to think of them sort of holistically too. And
it's scary and traumatizing if you're not used to, nobody's used to seeing their own body slit open. That's pretty gross, right? But as physicians, we understand, right? Like we know what's involved, but it doesn't mean it feels good having it happen to you either.
Or just seeing this gaping wound on your body and wondering, well, what are the next steps here? And I think that's where there was this lapse of communication for this patient. It was just like, she was told to go home and everything's fine, rather than this is our game plan. This is what we're going to do. This is what it's going to look like. And again, ER was not the right place for her.
Right. Yeah. Well, that would be a very expensive therapy session.
It was. And I'm not a therapist. I try my best, but you don't always get what you pay for, I think. So.
I think though that, so much of what I do is talking to patients, educating people, explaining things, telling them the science behind things, the physiology, how it works, what the experience is going to be like. I think that stuff is super important. And I want people to know exactly what they're in for when they're coming in to have something done, what the alternatives are too. So, if there's something different and better, I just tell people to go, do that. I just won't do stuff just because people are willing to pay for it. And I think that that's priceless. And if somebody's not giving you enough information up front, then I would not advise to continue with that person. If you feel uncomfortable, if you feel like, well, I don't really know what I'm getting myself into here, just walk away or get a second opinion, gather other information before you go forward. Because so often I really do think that doctors and nurses alike are not really great at explaining things to people who are non-medical. People use all kinds of medical terms and they don't understand them, and they, it's a low risk, so they don't explain it very properly. Even just the risk of vascular occlusion with filler, a lot of people don't even mention that when they're consenting people for filler. And I can't tell you how many people have come into my place and want filler. We've talked all about it, and we get to the consent part where we explain the possibility of vascular occlusion. And they're like, wait, I've had filler 5 times before and nobody ever mentioned that to me. And I just think that that's awful, right? Because God forbid you are the person it does happen to. You have no idea what's going on. You never thought it was a possibility. And I always feel that even if it doesn't, if it's such a low likelihood, I don't care. I want people to know, because if the thing does happen, whatever it is, well, she told me this could happen, but she also told me what they would do next. And so I'm okay. Like, I'll hang in there, as opposed to, if it's a total surprise to you and something happens to you and like, what the heck? You didn't tell me this could happen. Then you're angry, upset, you're freaked out, you're scared. I just think a lot of medicine is like this, but especially in aesthetics, where people minimize the risks and don't really acknowledge that they're there, much less, the likelihood they can have.
Yeah, and I think you, in your book, in Med Spa Mayhem, you did a really good job of kind of describing sort of like there's this glitzy sort of front to it. So you just expect all of the butterflies and sunshine, whereas, these are still medical procedures and should be approached as such.
Yeah. I mean, obviously I'm agreeing with you, with me. So yes, I totally agree. Tell me I want to hear the story about the Dimple doctor, because that one kind of blew me away. So tell me about him.
Yeah. So there's a physician that makes dimples, and people fly into town all over the country to have this done. And a patient had an area of their face. So this physician had made the artificial dimple and put the cute little stud there. And then unfortunately the patient developed bleeding. And
cute little stud. So let's back up for 1 second.
Okay.
Is getting dimples a really cool thing now? This isn't something I'm super aware of.
No.
Neo dimples.
My husband and my son have dimples. So naturally, it's, I guess.
So you find them cute, obviously.
I guess okay. He had made a dimple. He had made the little dimple, crater. And then there was a stud, like a little earring stud there.
Is that to keep it in place until it heals?
Girl, I don't know.
Okay. All right. So there's a neo dimple, we're going to call it, with a stud in it.
Yeah. There's
what happened?
With a stud, and then she had developed bleeding and had developed this hematoma, which is basically a fancy word for bleeding under the skin. And there's not a lot of space right in that area. And it had started to move down into her neck, and she was having trouble breathing. And so
that's a very big hematoma.
Yeah, very big. Right. And so, and it was so she comes in, and the surgeon is there with her, and I'm asking the surgeon, well, could this be arterial? Is there an underlying bleeding disorder? Just the basic questions. And then the surgeon was like, well, I made a stab here and I made a stab there. And so in that moment, I was like, wait a second. Are you a doctor? Why did you say, did you mean incision? What's going on?
We don't usually use the word stab typically.
No. If your shoulder pops out, I reduced your shoulder, which is the fancy word for I pulled on it until it popped back in.
Right.
But for all intents and purposes, I reduced it, So patient with this surgeon had already said that. And so I was like, okay, I'm not sure who you are and what you do, but what I'm going to do is call anesthesiology, because this patient her airway needs to be secured because there's still ongoing bleeding. She's having trouble breathing. And the surgeon was like, you just intubate her, meaning you put her on the vent right now, and I will open the area that's bleeding and let the blood drain out right here at bedside in the emergency department. And it was, I can only imagine this poor patient being like, what is going on right now? So I had to walk.
So he's basically treating you like you're a MASH unit.
Yeah. He's treating me also not like a colleague, right? But he's just, you do this thing. And wait a second, sir. This is not like a painless and risk-free procedure here. We have to take things into consideration. I had to walk the surgeon out and just like, hey, so this is my house and this is how we do things here. And ultimately the patient had to be, anesthesiology also felt like she was such a risk that they ended up putting a camera down her nose and then intubating her through her nose because of the swelling that she had.
Yeah.
So I'm glad the surgeon came with her to the ER, and took ownership of the complication, but also goes to show sometimes, I think even this surgeon failed to recognize the severity of this patient's process.
So was this surgeon operating out of a hospital or an OR, or,
Yeah.
he didn't have his own hospital to go to?
No. Yeah. So my understanding was that it was an outpatient surgery center, but
Which is legit. Those are real.
Those are real. It's legit, and he had.
But he couldn't go treat the person there because there was no anesthesia there.
I'm assuming that it was like the middle of the night. I'm assuming there's no staff.
Ah, okay. So no staff. Okay.
Yeah. So he was just like, okay, I'm going to go with you to the ER. Again, sort of was just like, do these things. And it's like, man, I don't think you realize, sir. Sir. So also I wouldn't have wanted to do something like that at bedside, like a crash, anything like that at bedside.
Right. So just like with the other case we mentioned, is that if anything does go wrong, you're not in the OR where you'd have all your supplies, everything you need in case there's a complication. So we generally don't take that kind of risk. We don't do things at the bedside that are risky.
Yeah. And I generally, I like the two physician. Whenever there's a procedure, I always want there to be two physicians there, just in case. That's my always two docs.
So Nadia, I'd really like to ask you about your company that you formed. I know that you're trying to disrupt the urgent care space and make it better. So your company is called Green Dot. Can you explain what you do and why you're doing it?
Absolutely. So myself and my colleague, Dr. Mark Amber, are answering the acute healthcare problem in the United States. So right now, up to 30% of Americans don't have a primary care physician. That percentage is higher amongst patients who are younger than the age of 35. And the average time to get in to be seen by your primary care, meaning you have one that you can call, is 20 days. So what do you do when you're sick or hurt and need to see someone sooner? So for Kate, what would you do if something happened to you and you're like, what do I do in this?
Well, me, since I'm a doctor and I do have a lot of resources, and I just recently signed up for a concierge doc because my previous doctor retired and she was an old friend of mine and I'd known her for 20 years and I could text her. So I feel like I have quite the privilege. I think most people would go to the urgent care. And I know that like my staff and, my daughters who are in college, far away, they go to student health or the urgent care to get treated because, you can't get an appointment with a primary doc that quickly.
Yeah. And just like you're saying, right, you have a doctor friend or, a concierge doctor or a physician, primary care physician that you've developed a friendship with and you can text. That's what I want to provide to everybody. So for those of us that don't have doctor friends or neighbors, they're Googling their symptoms, they're finding an on-demand health website, they're going to urgent care ER, and then you're seen in this piecemeal fashion, right, by providers and unclear credentials. And you pay a premium for this, and you don't know, these providers don't know who you are, you've never seen them before, and you'll likely never see them again. And on top
and
of
they
that,
don't necessarily know what they're doing. One of my staff members had strep, and they did a rapid test and didn't do a culture. And the rapid test was negative, which they're known to have a lot of false positives, a lot of false negatives. And so her strep went rip-roaring through her until I was like, you got to go get a culture. They should have done one, but, go back and get a culture. And of course she had rip-roaring strep and she went on antibiotics and she was fine. But I can't believe anyone working in urgent care wouldn't know that. Like, right. How is that possible?
And it's because you don't know who's treating you, right? Like you don't know if this is a PA or NP, or is this like a physician that is family medicine? Although family medicine doctors should know all these things, but you don't know what kind of doctor even is treating you. Is it an emergency medicine doctor? And we are the acute care specialists. So essentially, I feel like we can do a lot better than what patients are unfortunately handed right now. So for that reason, we've sort of walked through all of these pain points. And our solution is relationship, education, empowerment, and access. And that's where we created Great Dot. It's a virtual concierge acute care practice run only by board certified emergency physicians. So our practice, when you sign up for our practice, we are not the same price as a concierge primary care doctor, because we're trying to make this available to everybody, and a lot of times
not as expensive as a typical concierge doc, because that can really range, but can be pretty pricey.
It is cost prohibitive for most Americans. So what we did was sort of pull out the part of concierge that is the most valuable, which is 24, the relationship and the access. But so essentially you sign up for our service. We have an initial visit to establish a relationship before your acute issue arises. So when something happens, we're not going through what's your name, what medical problems do you have, what are you allergic to, who are you, right? We established a relationship sort of in a calm period. And then I send you a care kit to your house that expands my ability to care for and diagnose you and your family from home. It's basically all the things that you and I have in our pantries, right, to take care of our own families. And then finally, that 24/7, 365 direct access to the highest level of expertise from your phone without a call center and no middleman. So there's no nurse, there's no front office person you're talking to. You're texting me directly. And if I can take care of you from the comfort and safety of your home, your hotel room, wherever you're at, great. I'll take care of you. But if you need more than that is even, then I will refer you to the appropriate level of care and call ahead to let them know you're coming. In this way, we're trying to remove, illness doesn't need to be intimidating anymore. We're one of your doctor friends, essentially.
So it's like having you or me kind of, on speed dial.
Exactly.
For a nominal fee. So if you don't have a best friend who's a doctor, but even then, like having me on speed dial won't be nearly as effective as having you on speed dial. So really it's like having a super duper ER specialist to know how to handle any kind of medical emergency.
Right. And it's not just managing like the actual illness. A lot of times it's even patient navigation, right? What can an urgent care do for you? What can an ER do for you? If you have an eye issue, I'm going to send you to an ER that has an on-call ophthalmologist rather than just sending you to an ER that doesn't have that, where you may have to be transferred out in 6 to 8 hours. Right.
So going to the right place in the first place. So are you in every state in the country?
So we are currently in Georgia, New York, Texas, Florida, North Carolina, and Tennessee. So we started out in 6 states. I want this to be like an extra layer of coverage for, I think every person needs care like this. And I think it would really decrease the acute healthcare costs in the United States. It's just right-sizing urgent cares and emergency departments. And I think it would also decrease healthcare worker burnout, because a lot of us who are working in the ER, interact with patients who are just so unhappy because they feel like they didn't really get care in the ER. And it's not that they didn't get care. It's just that the ER is so used to managing people who are dying that when you're not dying, oftentimes it can feel like you're not being heard out. So we want to save you time, we want to save you money, and we want to make sure that you're getting the care when you need it most.
Well, wouldn't it be great if everybody in the country had that as a first go-to? I mean, it would keep so many people out of the ER who didn't need to go to the ER in the first place, which is, humongous in our country, really.
Yeah.
And then if you did need the ER, you'd get to the right one, and then they'd know who you were coming in. They'd be prepared to treat you. They'd know you were appropriate. That triage step's already been done.
Exactly.
Assuming your company has a relationship with the ERs, because if they don't know who's calling.
Well, one of the nice things about emergency physicians is we all give each other that professional courtesy. So if a doctor is ever calling in, I always pick up and get the report from the physician. I always call back. And I think most of us are pretty good at that, unless it's a crazy shift. And you know what? We all get that too. But I think part of all of this process too is accepting the fact that healthcare literacy is just not taught in schools either. So part of our process of this too is I send you the care kit and I teach you how to use it. And I teach you how to if you're not sure about something, this is what you can do to check, and so part of this too is teaching you how to be sick, and sickness is a part of life.
Well, that sounds really, are you willing to share anything about pricing? How much does that cost per month then for a family?
So we actually do year-long subscriptions, and that's just to that's really just to offset the cost of having someone available to you 24/7, 365. So for an
Sure.
individual person, it's $900 per year for 4 visits a year. And then you can pay for additional visits on an ad hoc basis. And really the purpose for that is to make sure that people are measured, right, when you're calling, so that we're not getting calls constantly. And then for a family, a family includes the adult, their domestic partner, and then 4 minor children that live in the home. So that's 6 people. And it's $1,800 for 8 visits a year. And the care kit is expanded to include pediatric supplies too. And so if you think
Okay, so that's $75 a month for an individual and twice that. So $150 for a family of 6.
Yep,
Okay.
exactly. And that's our introductory pricing for our first 200 patients. It's a 20% discount.
Okay.
But I'd like to, that first 200 will grandfather in, for the duration of their tenure with us. But, if I avoid one ER visit for you, then
yeah, it'll save you. Yeah, for sure. It'll save a lot of money. Well, thank you so much. I think that's really exciting. I wish you the best with your business, and I hope that model to me makes a lot of sense. It'd be nice to incorporate that into our whole, I call it big medicine, but like our whole system, so that people get triaged before they walk into the ER. Because I think that, in my opinion, so many people use the ER as their primary care doc because they don't have one. And, for minor things that as physicians, we would never go to the ER, people are going in, for things that you don't even need to treat, right? And so I think it's just this huge waste of resources and time and energy. And it's frustrating for the patient because the patient doesn't know, I didn't really need to go to the ER for this. And now I've got this medical bill. So I think that it's hugely valuable. So I'm really curious to see where that goes in the near future. It's very exciting.
Thank you, Kate.
Well, thanks so much for being here today. I love talking with you, and I look forward to the next time we get to talk.
Definitely. Ditto. And congratulations on your new book. It's wonderful reading.
Thank you. If you've learned something and like what we're doing, please tell your friends and give us a 5-star rating in your podcast app. If you have a question or a crazy story of your own you'd like to share, please send an email or voice recording to info@drkatedee.com. That's drkatedee.com. Or reach us through the website medspaamayhem.com. And read the book. Med Spa Mayhem is available everywhere books are sold. Thanks for listening. This has been Med Spa Mayhem with Dr. Kate D. We are so grateful you're listening, and we hope you've learned at least one fun or possibly disturbing fact today. Don't forget to hit subscribe on your podcast app and leave us a 5-star review. And read the book. Med Spa Mayhem is available everywhere books are sold. Links and more can be found in the show notes and on medspaamayhem.com.